I extend a warm welcome to each and every one of you to this esteemed event of the Aesthetic Medicine Conference and Exhibition 2024. I am Shriyal Sethumadhavan, the editor of Aesthetic Medicine India, and with great excitement we embark on our fourth physical edition of the Aesthetic Medicine India Conference and Exhibition, where we bring together some of India's most esteemed aesthetic medicine practitioners who will captivate us with their expertise, exchange ideas, and push the boundaries of aesthetic excellence. Today, we gather here to engage in a comprehensive exploration of the world of aesthetics as we delve into new techniques, share experiences, and unveil cutting-edge treatment modalities designed to cater to the ever-evolving needs of our valued clients. Aesthetic Medicine, a distinguished B2B magazine catering to discerning aesthetic professionals, originated in the United Kingdom 20 years ago. The Aesthetic Medicine Expo and Conference, introduced in India in 2019, serves as a vital platform connecting the medical fraternity with supply chain stakeholders, facilitating networking, sourcing opportunities, and training initiatives. And this month, we proudly celebrate 5 successful years in India. Thank you. Our journey would have been incomplete without the unwavering support of the aesthetic medicine fraternity. To our extraordinary aesthetic medicine practitioners, aesthetic dermatologists, and plastic surgeons, esteemed partners from the pharmaceutical and aesthetic devices spaces, our dedicated readers, and each and every one of you present in this room, we extend our heartfelt gratitude. Going by the industry scenario, we see that the global aesthetic medicine market is to hit the market valuation of US $212 billion by 2032 from US $75 billion in 2023. That's a CAGR growth of 12.17% during the period 2024 to 2032. Let's talk about the Indian medical aesthetic devices market size. It is estimated at US $1.62 billion in 2024 this year and is expected to reach US $3.2 billion by 2029, again growing at a CAGR of 13.28% during the forecast period. The major factors driving to this industry are the rising adoption of aesthetic procedures, new technologies, and the need for beauty enhancement procedures. So with this, we will now move on to our first panel discussion for the day, new modalities and strategic management in acne in different age groups. I would now invite our moderator, Dr. Madhuri Agarwal, celebrity dermatologist and founder and medical director, Yavana Aesthetic Clinics, to please join me on stage. While she joins me, a few words about her. With more than 16 years of experience, Dr. Madhuri Agarwal is a global leader in aesthetic medicine. She pioneers advanced treatments, regularly sharing expertise internationally. As a sought-after speaker and trainer, she educates peers on cutting-edge techniques in laser, facial rejuvenation, anti-aging, and dermal fillers. I would now invite our panelists who would be joining Dr. Madhuri for this session. Please welcome Dr. Sejal Shah, aesthetic dermatologist, Visage Skin Clinic. With over 20 years of rich experience, Dr. Sejal Shah has demonstrated expertise in facial rejuvenation and contouring using advanced techniques such as fillers, threads, botulinum toxin, and skin boosters. Specializing in pigmentary disorders, acne, and hair concerns, she has been invited to numerous workshops, presentations, and panel discussions on aesthetic procedures, including botulinum toxin, fillers, threads, and lasers. Next, Dr. Shefali Trasi Nerurkar, consultant dermatologist, Dr. Trasi Clinic and La Peel Skin Clinic. Dr. Shefali Trasi Nerurkar is renowned for her expertise in treating a wide range of skin, hair, and nail conditions. As the third-generation dermatologist at Trasi's Clinic, she brings extensive training and membership in prestigious dermatological associations to her practice. Specializing in acne, acne scars, pigmentation, and anti-aging procedures, she also provides training in advanced treatments like botulinum toxins and fillers to fellow doctors. Dr. Manu S. Walia, head dermatologist, Myra. Dr. Manu brings over a decade of clinical and aesthetic dermatology expertise to the forefront, specializing in delivering care for patients of all ages. Her skills encompass a wide range of dermatological therapies, including botulinum toxin, fillers, chemical peels, threads, PRP injections, and microneedling. And Dr. Rinki Kapoor, founder and director and consultant dermatologist, the Aesthetic Clinics. Uh, Dr. Rinki Kapoor is the founder-director of the Aesthetic Clinics, a chain of aesthetic clinics in multiple cities in India. She is the inventor and patent holder of QR678 hair and skincare invention line. She is the mentor of the Premium Aesthetics Training Institute in India, IAFCS. She is the director of Deba Batra Oro Foundation, a philanthropic organization devoted to humanitarian care. Thanking all my panelists to join us today, and can we please hear a huge round of applause from them? Let us be louder than the space in this hall. And requesting Dr. Madhuri to take it forward from here. Doctor, we have 50 minutes for this discussion. Over to you.
Thank you, Shriyal. Thank you, Mr. Vikasvij, Shriyal, and the entire aesthetic medicine team for being a partner for so many years successfully and helping us. Can you help me with putting on my panel? So it's a lovely morning, and I think we are going to learn from each other is what the objective is more than, you know, the audience. And it is giving me the Karan Johar coffee with me feels. I'm not going to wear my Budhape ka chashma. As dermatologists, we don't grow old. Pen drive. So I think acne is very prevalent, and for now it's a growing issue for us. And I like the fact that they said that let's talk about all age groups. So yeah, we'll have it on the screen. We have challenges, we have not so many new modalities, I think we would say, and also what are the management strategies that we each of us are doing. So yeah, these are our panelists, and all of them are dear friends out here. Now, acne, as we said, in all age groups, both men and women. But we are seeing a large number of our patients coming post 30 saying that, Doc, I'm growing old, I'm past my teens. Why am I suddenly getting acne? And the standard thing I tell them is, Aap jawan ho rahe ho, right? And men also are coming to us. Maybe it's stress, maybe it's those gym routines, maybe it is lifestyle. So nothing seems to be working for them. We know it's multifactorial. We have learned this in our PG days. And you know, we grade them as per severity and accordingly treat our patients. So we have these three group of patients. This is my panelist. We start here. So we have patients who come with that one pimple and that one big comedone and say, Doc, my life is going to end. Please do something about it. And then secondly, we have patients who have tried various products, online, offline, various doctors, damage the skin, and they come expecting you to do magic in a day. And lastly, you have patients who don't bother about it, and maybe somebody, the spouse has pushed them, or they have an opportunity where they want to look good, so they come. So what are the kind of patients you see frequently in your practice? Dr. Rinki, do you want to come on this chair so it's more comfortable for you? Yeah. So starting with whoever wants to take this. What do you normally see? Do you see all of them? Do you see specific set? Yes, Dr. Shifali, let's start with you.
So what nowadays we see is grade the type 1 and the type 2, which are very common. So it depends upon the generation that you're looking into. If it is a Gen Z population, then a single comedone affects them and affects them morally, you know, psychologically quite a lot. But the millennials, I think they would come with, or some of the Gen Z as well, they will come in grade 2,
yeah,
wherein, you know, they have already tried everything what their influencers have told them and what their chemists have told them. And then when finally everything has failed, they have come to you with all the side effects, telling you that I have already tried tretinoin, I have tried niacinamide, I have tried vitamin C, and I wish to use these products. Also, there's one more set which tells you that I wish to use these products, but you treat me and clear of these acne in probably 7 days because I have a wedding or a function coming up soon.
Perfect. Dr. Manu, you want to add something before we move to the next?
Yeah, it's on? Yeah. So as Dr. Shifali said, so one set is this. Another is, I guess, people are very much aware these days because of the influence of social media, all these things. Even grade 1 acne also, they are so aware. They are aware about that they'll land up with scars. So because of that consciousness also, many people land up in the clinic seeking for the treatments.
Yeah.
So I've seen that set of patients also.
So I think we are fortunate.
Which
we are
is
in that
good in
area.
a way,
Yeah.
I guess.
We are in an era of awareness wherein we see patients who come early on, and it's easier for us in a way. Obviously, that set of products has their own patient. So say a patient of acne has come to you, Dr. Rinki. What do you normally suggest as a dermatologist? Your first line of management, typically maybe a moderate acne patient is come to you. What would be your approach to these kind of patients?
Yeah, so first, the main thing is the history. That's very important. And we always ensure that we take a very detailed history of any patient who comes in for the first consultation.
Absolutely.
Because nowadays, a lot of people, they do all these DIY things and all. They go online, they look for products, they apply this and that, and then they have all sorts of problems. So the history is very important, as in it's a first time acne that they're getting, or it's been a long term history. What is the age? Then what is the products that they have used, any doctors that they've seen before, anything they've done at home, how is their diet, how is their exercise routine, what do they eat, what is their stress levels, hormone status for females, young girls who come nowadays. They start menstruating at the age of 10, 11, so you have to ask a menstrual history even in a 9-year-old, 10-year-old girl nowadays. So that is all there, all that you have to ask. What is the routine that they follow, the skincare routine, whether they're using makeup, they're using a face wash, they're using toners, they're using night creams, what all are they using, sometimes it's the products that they use that cause problems. So the detailed history is very important, and then you go ahead and decide what grade of acne they come into. So whether they come into grade 1, grade 2, we have all those classifications for acne. Of course, that is more for theory, but I think we have to classify patients based on what they have, whether they have
Absolutely.
inflammatory, non-inflammatory, or they have cysts, they have nodules, they have severe acne, they have scars. What do they have? They have PIH. What is it that the patient is more concerned about? Sometimes people are like 3-4 acne, they don't bother, but they have a lot of acne that's bothering them. Sometimes there are patients who don't bother about facial acne, they bother about more their body acne. That's more disturbing for them. So what is it that they're more concerned about? These are all the things I think that we need to clarify before we customize their treatments.
No, I agree totally. As dermatologists, we should not lose sight of the fact that we have to do a proper, as we learned in our PGs, you do your history, you see where did the origin, what is the current status, what is the medical history, what are the severity of the lesions, any internal factors. Also, the age of the patient matters a lot, whether it's reproductive age group, menopausal, what is it, and also how compliant they are to the therapy. So, any specific preferred topicals for acne management, Dr. Sejal? What about the newer, since we are talking of new modalities, are there anything new which you feel is exciting, or you feel the old tried and tested is good enough?
Yeah, my favorite is actually the topical retinoids.
Take the mic closer to you.
Topical retinoids, that's my first line of treatment usually. And so maybe tretinoin topically, adapalene. I have used trifarotene in some cases, yet to see the results. And yes, benzoyl peroxide as well. So these are my go-to in most
Dr.
cases.
Shefali, you want to add anything on the newer modalities? Or?
I think the older modalities are good enough. And if we combine them properly, like not only use the clindamycin alone, standalone, if we use in a combination, so the clindamycin with benzoyl peroxide or clindamycin with retinoids, I think the results are better. So the older formulations only, the older products, not the formulations, the benzoyl peroxide, the tretinoins and azelaic acid.
Absolutely.
I think all those are working quite fine for normal acne.
Do you want to add anything, Dr. Manu?
Yeah. And one more, with any topical modalities, benzoyl peroxide is my favorite because many studies and these are showing that adding benzoyl peroxide prevents the bacterial resistance also.
Absolutely.
Which is very, very important these days. Many patients, people, they're coming with resistance, which is a challenge for us in the treatment.
Especially with systemic.
Yes. So even they said with that, if we add benzoyl peroxide, it prevents the resistance, so it's good.
Yeah.
I mostly try.
Yeah.
Yeah, one more thing, I think nicotinamide is also helping. So nowadays we have these combinations of clindamycin and nicotinamide. I think that's doing really well. And I think the alternative therapies also, some of them, these botanicals which are there, They're very good for mild acne. They're very good for incorporating into face washes and things like that, acne masks. So these are some things I think they also help to some extent.
Agreed. No, I agree with the panelists that old is gold. And while we need new modalities in certain conditions in acne, I think the older molecules have proven their mettle. And right now, the new molecule trifluorotin is still being studied. It's still being watched upon. We don't have enough data. So I think we're happy with the older molecules, as we said. And adding alternatives always helps. So systemic drug, as we talked about, we use, and you know, we ourselves as dermatologists use and abuse systemic because we want that instant relief. But resistance, we have to keep in mind, and that's where your topicals matter. Sunscreen in acne. Patients come to you and say, Doc, my skin is already oily. Whatever sunscreen you give, it just doesn't work for me. Is there a favorite way of, you know, talking to your patients, or is there a favorite sunscreen that you would want to give? Does tinted make sense because of the PIH? Dr. Sejal, do you want to take this?
Yeah, I do recommend sunscreens to all my acne patients.
We all do, but how do you manage to convince your patient to use it?
So I convince them that you do need photo protection. One is obviously, yes, to make sure that your PIH doesn't increase beyond a point, but also to make sure that there's no, most of them are again on therapies like isotretinoin or a doxycycline or topicals mainly, which cause a lot of photosensitization. So I do tell them to make sure that they're using a sunscreen to prevent further damage to the skin, because the skin is already dry, sensitive, irritated, and which can further increase the pigmentation on the skin. So I convince them, I tell them, put them on a water-based sunscreen or a gel-based sunscreen. If they have PIH, then yes, I do tell them to use a tinted sunscreen, which gives a slight coverage to the skin as well.
Dr. Shefali, what about you? You have the celeb patients. What about those CC creams and the makeup?
Well, I feel that if you talk to your patients like you're talking to your friends and explaining them the importance of a sunscreen, it does work. Because here I tell them that I am giving you an anti-acne protocol, but at the same time there are certain products which are going to cause pigmentation. And at one end I'm going to treat your acne, second end I don't want you ending up with pigmentation. So if I tell them, if you educate them, then many a times they do agree to it and they start using it. The other approach that I have taken is, nowadays we do have formulations which have moisturizer and sunscreens together. So in acne, I know my retinol or my benzoyl peroxide or my glycolic is going to dry the skin up. At the second end, if I give them a moisturizer with a sunscreen, though the sun protection may not be ultimate, but at least I'm assuring myself that at least morning, if cream they apply with a sunscreen in it, there will be some amount of photo protection. The patient will also be happy because, you know, the dryness caused by my overnight retinol has gone down. So that is one of the other ways that I try to, you know, incorporate sunscreens in my acne prescription. And the third, as she said, I try to use a nice gel-based sunscreen or nice matte finish sunscreen which does not have a oily finish to it.
Or a white cast.
Yeah, no white cast to it. And I'm not a big fan of BBs and CCs. However, if they still tell me I want to use it, what I tell them is use my cream at the base and then use whatever you want to use.
Dr. Rinki, you want to add something?
Yeah, so actually, you know, a lot of people, they want to use sunscreens. They know that they have to use it. They come asking, okay, we want to use doctor, but then the skin looks so oily. I just break out because, so the thing is that you have to prescribe the right sunscreen. So if you tell them, okay, I'll tell you which sunscreen to use, then you won't have problems. That is, I think, that's where they catch it.
I think as dermatologists, we have to open ourselves to, one, come down from that high ground if we are doing that, and explain even a little thing, because Google doctors everywhere. If tomorrow you don't explain them, they're going to another doctor who is friendly enough to do that. Secondly, we ourselves should experience all the products, maybe not on the face, but give it to your internal people, your therapist, your staff, try it on your hand so you understand how the formulation works on a skin before you prescribe to your patient. That's what we sometimes overlook, you know, and this is very essential because without that confidence, we cannot give it to a patient. Coming to a larger growing group of acne patients, which is your pediatric and your preteen. As I mentioned, menarche starts early. We have 10-year-old and parents. We are the millennials, are the parents, and we know how much of an impact acne can give. So we are the ones who get our children to the doctor and say, even that one acne can cause scarring because I had it. So that hangover is there. So Dr. Manu and Dr. Rinki, would you want to enlighten how do you manage, I think Dr. Rinki, we have a case of yours, so we'll discuss that. Dr. Manu can add.
Yeah. So very important in preteen age group. So sometimes I've seen more than the patient, the parents are more concerned
Exactly.
and worried. Sometimes just a 1 or 2 acne, they are more concerned. So I guess the biggest part before the treatment is counseling them, making them understand that just few lesions is not a big concern. But yes, if they, we can always prescribe some, face washes and all. We're talking with these components, add-ons, some salicylic or glycolic-based face washes can be given if they have more. But yes, if acne is severe, we do go for a treatment also. But counseling is very important.
True.
And in this age group, it leads to low self-confidence. So that has to be taken care
I think
of,
हमारे
guess.
टाइम में भी था, but
Yeah.
मम्मी पापा 2 थप्पड़ लगा के बोलते थे जाओ
they used
स्कूल.
to be like, yeah, that's okay, but these days,
हाँ,
yeah,
now
the
these
reverse
days
trend.
बच्चे हमको थप्पड़ लगा के बोलते हैं चुपचाप हमारा ट्रीटमेंट कराओ. So I think that is the change.
So these days, parents are more anxious.
Exactly. So Dr. Sejal, that's your case which you shared with us. Would you want to tell us about it? This is the teen you told me.
Yes, she was a 17-year-old. So she came with, I would say, grade 2 acne, a lot of papules, pustules, and a lot of erythema. And I started a treatment on a routine line of treatment, started her with an antibiotic, topical application. She kept responding, then again used to relapse. And this went on for almost 6 months. Absolutely no history of any missed periods, no hormonal concerns. Even the pattern did not really suggest anything of that sort. Then incidentally, she had a twin sister who got diagnosed with PCOS, which made me then put her onto a sonography which detected PCOS in her. So what she responded to at the end was oral contraceptive pills. So the point is that they may not really have any history at that age. Normal periods, no hirsutism, just the acne, no family history of acne. And incidentally, you might just pick up a hormonal disturbance and then you have to treat it accordingly.
Got it. I think very valid point. Hormonal, especially with the insulin resistance being on rise, even in youngsters, we have to look. Dr. Rinki, this is your patient you shared with us for teen acne. Can you help us with the details and how you handle this patient?
Yeah. So this girl was, I think she's in the 8th standard or something. So she's around 12 and she has mostly comedonal acne. Her mother got her. She was least bothered about it, the girl. And I think what happened was the first thing I asked her is whether she's washing her face. You know, these teenagers, no, nowadays, they are very lazy with some things and they're very active with some things. So they are like all the time iPads and this and that. They don't bother about, there are extreme cases also wherein they are like finicky about one pimple also. But in general, no, I like have teenage boys. It's so difficult to get them up in the morning to wash their face. No, I sometimes feel irritated. So they
And you break out because of that?
Yeah.
Do you break out because of that?
No, I don't, fortunately. But it's a tough thing. So she never used to wash her face regularly, and then her diet was also so and so. So you have to ask these questions. What do they at least wash their face twice a day? Because these people play a lot, especially boys and all. They play in the sun. They play a lot. They sweat. And then they don't bother to, manage things like that. Then this girl also had dandruff. So you have to ask questions about dandruff, whether they're oiling their scalp. Because if you see the pictures, a lot of acne on the forehead, okay? So that is one thing. She had just begun with this thing, her period. So menarche had just set in. So probably that's the reason that she was breaking out. There was a family history in her mother. So family history is important because genetics play a role in acne. And then, so generally pediatric acne is very mild. It's not like very bad or major. So topicals, topical antibiotics, face washes, and maybe a little retinoid if there is comedonal acne should do the job. But the only thing is that the mothers have to be after these people because, and the parents are like, don't give tablets. They're very skeptical. Bachcho ko tablets kyun dena hai? And things like that. So generally they want topicals and that is what they follow. And if you instruct the mothers well or the father, whoever comes in for the consult, they generally follow it. And I think that's the way to go about it. Procedures we generally don't do under 15 years of age. So that's how we manage. And these people have to be told that since their skin has started breaking out very early, they're going to face acne problems later.
True.
So they need to be careful, and maintenance is the key in such cases.
I think that's very important. As an education, we have to tell them the course of disease. They should not expect that doctors given a prescription. So you have to tell them this is like, you know, a long-term thing, no cure, only control. And you come to me twice or thrice a year when the breakouts is more. That's how I counsel my patient. And the remaining you manage with your therapies at home. So, and I think I see a lot of 10, 11, even 12 years old coming with vitamin C, mucin, and retinol, and yes, I don't know what all. I've never used it in my life. So, and they are so brainwashed. So, a lot of time you have to spend in counseling with these patients again and again. That's very important. So, coming to procedural treatment, Dr. Shefali, do you start during the first consultation, or do you do it only when they're not responding to the medical line of therapy?
I never start during the first consultation, because the thing is that when the patient comes to you, they are new to you. You don't know how much of, sincerity and adherence they are going to have to that particular treatment. Also, you don't know what they have applied in the last few days. So if they have been applying some retinol, because many a times I've seen patients do hide a lot of history from us, because they feel that, what will the doctor say that I have applied this. So first, when the patient comes to you, you need to see how much can they adhere to the treatment, whether they are sincere enough for getting those treatments done. Then in the second consult, you can always tell them that, this is a type of acne you have, and I do wish to do these treatments for you when you come back next to me. But can you just start with this treatment for the time being? And then when they come to you for the second consult, then you sit down and then you can jot out a plan, that I wish to do chemical peeling, or I do wish to do microdermabrasion. Probably for scars, I want to do some fractional lasers for you. But not in the first consult, because you need to understand where the patient is, how the patient is. Because once there are any side effects, it will be completely your, the entire ball will be in your, this thing. Okay. It will be your mistake that you did not think about all these things.
Agreed. So, Shreel, we have some time, right? I'm going to run through some cases. And what about closed comedons? A lot of these patients now come, these tiny white heads, maybe 1 to 2 millimeters spread all over the face. Sometimes they're not visible except to them. And when you go closely and look at it, you can actually see those macrocomedons, which is, nothing seems to be worked. So what is your line of approach? Sejal, you want to take it?
So where comedons are concerned, and when there are so many of them, I usually prefer doing a comedon extraction, because honestly, without really opening them up and taking them out, the existing ones take too long to respond. And simultaneously, yes, I would put them on a benzoyl peroxide and adapalene combination. But I think taking them out is the way to go.
Dr. Ringi, you want to add something to this?
Yeah, that's what. So extraction, and depending on the age of the patient, of course, and considering topical retinoids, if it's really bad, if it's involving a larger body surface area, then oral retinoids. That's the way to go, I think.
So I have a little different approach. I actually start them on oral isotretinoin and counsel them for the first 2-3 months you're going to break out really bad. But long term it helps to give a resolution, because sometimes extraction itself leads to a lot of scarring. So yes, the combination for me works very well. This, what happened is, when I asked my panelists, out of all 4 of them, 3 sent me these kind of cases, and this is what we are living in the real time, and I had to pick and choose. So I have just picked one case of steroid. I think this is what you sent to me. And how common is this, and how do you manage these patients?
So in fact, she's a doctor herself. And during the lockdown, she used to break out occasionally, that usual premenstrual flare. She had a little PIH for which she went to a clinic, so-called clinic close to her clinic. And the doctor there started her immediately on peels and lasers and some kind of facials, and then gave her some cream from her clinic. Now she kept applying it, kept responding, it started looking really good. And then all of a sudden she broke out into majority what I could see were papules, pustules, but a lot of closed comedons there. So in her case, initially when she came to me, I started her on antibiotics, wasn't responding, put her on isotretinoin, caused an initial flare, and then she started developing severe headaches. So I had to take her off that. Now she was one case in which I had to start her on peels and also her carbon Q switch laser quite early on, because she wasn't responding to anything. I put her on spironolactone as well, thinking that she does have a hormonal flare, which does still happen. But she did respond well to extraction of the comedones, peels, and a carbon Q switch.
And how long did it take you to treat this?
She still off and on comes to me, but it took me almost a year to get these under control. Like it took me 6 months to just get the new comedones to stop coming, and then to settle down the PIH and all that. Like this is somewhere in between. She's a lot better now.
What about you, Dr. Shefali? How do you handle steroid cases?
Well, first of all, I tell them that I'm going to stop your steroids, and it's going to be like alcohol withdrawal. You are going to have that, wanting to apply a steroid again, because it gives a nice, flawless skin. It gives that nice glow on the skin. So you have to talk to your patient that, from 10 pegs, I'm going to put you down to 5, and then 3. I can't do that. I'm going from 10 to 0. So you are going to have that desperation to apply that cream again. Secondly, I start them directly with all the acne treatments. In case I see inflammation, you have to give them antibiotics and lot of hand holding. You have to tell them each sitting you have to spend that additional 10 minutes, counseling. It will get fine. You are going to improve. And in these patients, in the second sitting only, I would start using chemical peels, because, you are constantly in a race against that steroid, and you need to win that race for the patient, because patient is the sufferer in that.
Absolutely.
Okay, many a times they don't know what their previous doctor has given or
Please
what
don't
the
take
chemist has
pictures.
given.
Doc, please don't take pictures.
So you have to, for the patient, you have to try to win the race. So chemical peeling, microdermabrasion, intense pulse light therapy, blue light, all these things are going to help you in active acne, and we should use them early in our practice.
Just a request, before, after, please don't take. The other slides you can definitely take. So yeah, this is one of our patients who was not affording, couldn't afford, even oral ISO couldn't afford any peels or treatments. We have treated over 8 months with the topical tazarotene and some antibiotics and obviously basic skincare. Yes, steroid takes a long time, up to a year. That's what the point I want to highlight. You have to counsel your patient to be prepared. This is a patient who comes to you, young girl, and no matter what you do, she just comes back with these lesions. What do you think this is? She's just picking and picking and picking.
Acne excori?
Yes. So this is a typical patient who comes, especially young girls who are not very confident, and you see this typical excoriated PIH. How would you manage such patients? Dr. Manu, you want to add something here?
So again, in such cases, again a counseling, and if they're very young, we need to talk to the parents also and make them understand. Sometimes underlying stress at this age, their school issues and all those are there. Once we counsel them, make them understand, then we start a treatment for them.
Would your line of management be same as your regular acne, or would you want to change something in this?
So mostly regular, I mostly start with the topicals first. If very severe are there, then I consider giving orals also, like oral antibiotics. Mostly start with the topicals and also simultaneously work on improving their scars. Because the more they scratch, they do this, the more they land up with the scarring. That again has a psychological impact on. So it's like a vicious cycle. So we have to break that cycle.
Dr. Sejal, you want to add something?
Ideally, acne excori should be referred to if not a psychiatrist, at least a psychologist.
Absolutely.
But it's very difficult to convince parents to take their child for a reason like this, or even the patient themselves, an adult patient. So I do then advise them that at least start with means to reduce your stress or whatever is causing it. So start with a yoga, meditation and all that, but I do definitely put it on paper that they need to see a psychologist or a psychiatrist.
So yeah.
If not handled by
Dr.
parents.
Manjusha Kurwa is here, our senior. She wants to add something. Can we have a mic for her, please? Sorry, yes,
Till the time she gets the mic, I would like to add one more molecule, beta-lactam.
Absolutely.
It helps to relax the patients, because acne excori is something that we see more often when the patient is much more relaxed and not having anything to do. So at that time they start picking on their acne. So if you try giving beta-lactam capsules to them at night, it will help to relax their mind, and chances of excoriation can really go down.
Yeah. Dr. Manjusha, yes.
Hello.
Yeah.
Actually, what I tell all my patients who are little bit cooperative to use the hand gloves, the cotton hand gloves. Whenever they are free, they are using hand gloves.
Nice.
So this is every night whenever usually they watch TV or they are with the social media, and then that is the time when they have free time to prick the skin.
Yeah.
So, and this I use for the habit of the nail biting also. And I'm seeing amazing results. They really cooperate.
I think we have to think beyond the box. Besides your conventional anti-acne, anti-anxiety, and these kind of physical measures sometimes really help, because till you train the mind, you have to train them to do it consciously. You have to subconsciously work on it. So Dr. Shefali, you have shared this case with us. Can you let us know how did you manage this case? Beautiful results.
She is a 21-year-old female, and I think studying for engineering, and she was suffering from nodulocystic acne, and thin, lean female, but similarly she later on got diagnosed as PCOS. So we investigated her thoroughly. We started her on spironolactone, not improving. Also, she was developing a lot of hair loss. So in this case, we referred her to an endocrinologist. And together, as a team, they improved because her testosterone levels were very high, DHEAS is also not in control, prolactin levels had come out to be very high. So with the help of an endocrinologist, I tried getting all those levels in control. And then simultaneously we started first with oral antibiotics, then oral isotretinoin, topicals such as benzoyl peroxide, clindamycin, and retinols. And then in the 4th or the 5th session, I started her on fractional lasers. Because she's a young student. It was hampering her confidence to go to her college. She did not want to go to college because of the nodulocystic acne. So started immediately in the 4th session with the fractional lasers as soon as the infection went down. And yeah, we got a good result with her, not only her
fantastic results,
acne marks as well as the scars.
Yeah, I think for them scar is also primary, and it's important that I was going to talk about later, but we should work as a team. Like, we don't like people coming in our field. I'm sure others don't like us behaving like endocrinologists and gynecologists and treating people. So generally, when I partner with an endocrinologist, a nutritionist, counsel her for exercise to manage such patients beside your conventional medication. Female patient comes to you with these monomorphic lesion, mild pruritus, typically in the back, sometimes on the shoulder. What would you think of? Anybody from the audience also can pitch it.
Post-vaccine folliculitis.
Absolutely, perfect. That's very important to consider. It's not always all is acne. There could be other pathologies or contributing factors too. A very common scenario, gym fanatic, sudden acne, male patient, even females, but more of male, and face and chest and back is afflicted. Now, this is a common question. Does whey protein, doc, should I do whey protein? Dr. Rinki, would you want to take this? How far is it true?
See, I don't think there are any studies, hardcore studies, which prove or disapprove this. But in clinical practice, what we see is there seems to be a correlation. So the amount of whey protein that you're taking in is probably correlates with the flare-up of acne. And I think because these gym guys and all who take 2-3 scoops of whey protein, because whey is ultimately casein, it's coming from dairy. So I have seen that, and especially if they have casein and creatine mixed, things like that, so it probably is a cause. So what we tell these patients is, if you feel that a certain dietary thing or a certain supplement causes acne in you, then it's better to be avoided. That's what I recommend.
Any further? We have another 5-7 minutes, so we'll quickly run through it. But yes, deficiencies, not only whey, even iodine, which is then kelp, and vitamin B6, 12, steroids. So most of these people are taking creatinine and they're also taking anabolic steroids, which they are not aware of. It's part of the protein at times. They're not into fat burners and body mass gainers, which all are sisters of any form of steroid. So do take a detailed history. I ask them, the acne patients, what are you taking, including supplements. They take a lot of omega-6, which can also contribute. So this is important for us to remember. Yeah.
So very important. I mostly ask such patients that during their next visit, get a picture of the ingredients of their whey protein and any other supplements. So these days, these gym instructors, they are only guiding them what products to take. So anabolic steroids is a major concern. And not only acne, because of this, they present with androgenic alopecia also, highly progressive. Yeah.
Perfect. So this is another patient. It's a challenge. That's why we are talking of challenges. Female patient, long-term antibiotics, suddenly coming to you with this itchy, dry, uniform, flesh-covered, whitehead pimples, not responding to anything. What would you think of? Gram negative? Yes. So always look for, if they're not responding to the conventional things, always do a culture. And generally, these patients respond to ampicillin or oral iso as well. This Dr. Manu Walia, you want to share this patient? How did you manage this? It's really bad.
So so this patient, she presented with this severe acne in her mid-20s, and there was no history of any steroid use, though she was having acne since long time, but she was not taking any treatment. She was doing some DIY things at home. So, the approach was, we consulted her for that you will need, multiple treatments. The combination therapies will work for you. So I started her on oral antibiotics. And later, some of the very resistant nodules, we have given intralesional steroid also. And initially, she was not ready for isotretinoin. So she didn't give the consent. But later, I started. And anyways, in such cases, I usually prefer to start with antibiotics first, because in these severe acne, sometimes
which was the preferred antibiotic in this case?
So so I was thinking for moxie and clavulanic first. Too much of this thing was there. Pustules and discharge was there. She, to our surprise, she responded very well. And later I started her on isotretinoin also. Not initially. Sometimes we have seen such severe cases when we start them on isotretinoin, sometimes a lot of flare happens.
Absolutely.
And in this patient, already she was so flared up, I didn't wanted her to flare more. And of course, topicals were also started, benzoyl peroxide, clindamycin and all this. And later peels, salicylic and glycolic peels were also used for her, but she responded very well.
Yeah, maybe sometimes in these patients, as we talked about, sometimes a swab helps us identify the bacteria to give the antibiotic, because it looks like a superimposed infection and not a typical. Acne in pregnancy, we generally, I'll just skip this because we don't have time, but yes, we have very limited options and we can look at our physical therapies here. Persistent acne does not seem to go. This is a very common condition. What you do, they have some moderate acne, which keeps on coming. Whatever you do doesn't help, and PCOS is a diagnosis of exclusion. I think we jump to, do label everything as PCOS, but what I've learned from my seniors, it's a diagnosis of exclusion. Dr. Rinki, this is your case, so let's go to that. You have 2 cases, so let's talk about both these cases that you have shared with us.
Yeah. So this is a 25-year-old girl, and she's got acne. You see the acne is more on the lower face. Okay, so the upper face is practically clear and very bad hirsutism. So the entire lower face has thick hair, and the body also she's got hirsutism. So typical case of hormonal imbalance and all these symptoms. So evaluate. So in such cases we do an ultrasound, because she's never gotten it done. So we did an ultrasound for polycystic ovaries. We did an entire hormone profile, because such cases with bad hirsutism, bad acne, it's always better to do a hormonal profile, blood hormone profile. All that was checked. Then she had high testosterone levels and prolactin. So then she was referred to an endocrinologist. We started her on treatment for acne. So she was initially put on oral antibiotics, of course topicals as well, and then oral isotretinoin, and she was put on laser hair removal. So because hair was a primary concern, lot of hair on the face, so we did one thing to note here is despite being on oral isotretinoin, we put her on laser hair removal. So that's not a contraindication anymore. If you're not on a very high dose isotretinoin, if it's like typically she was on 10 milligram OD, and that's not a high dose, you can safely do all laser procedures, there's no problem. In fact, even a fractional laser for that matter.
Yeah, and this is another case of your similar management, would you say?
Yeah, so again, this is basically more, she had come for the PIH after acne. Her acne had more or less resolved. So we put her on, we did a combination peel for her and brilliant results. And she was also on topicals for maintenance for acne. So I think that's the thing. Yeah.
I think last few slides, I'm going to click back acne. Again, Dr. Rinki, this is one of your patients.
Yeah.
So you can talk about it, and I would like Dr. Sejal and Dr. Shefali also to pitch in. How would you manage back acne?
Yeah, so this patient didn't have acne on the face, absolutely clear. And it was just the back. So it's truncal acne, back, buttocks, the thighs are involved in this case. And so we treated the acne, standard lines of management. He was put on oral isotretinoin and things like that. Very good response. Then he was left with marks. So for these marks, then we started him on peels, etc. and doing really well. And one thing to note, oral isotretinoin, he initially also had taken it, but he was keeping on relapsing. But when we inquired, the history was, he mentioned that he'd taken it in phases. You know, these people take it for 2 months, then the acne is clear, then they stop, then they take it again for 2 months, then they stop. So that's what is happening. So if an entire course properly is given, then the relapse rate is very low with oral isotretinoin. So that's how we did.
Dr. Shefali, Dr. Sejal, you want to add something, or would you manage the same way? Similar?
I think back acne you'd want to manage the same way. Isotretinoin with glycolic acid peels, and in case of very stubborn marks, then even TCA peels work very good for the post-inflammatory hyperpigmentation, and the topicals will remain the same.
Dr. Sejal, this very popular carbon peel is what people are talking about and coming asking. Carbon peel is very popular nowadays, and people do come asking, do you think you would do it for a back?
For larger body parts, I usually prefer not to use that. I prefer peels. So, and they do respond pretty well to peels anyways. So carbon Q switch is what you're talking about, right? So that for bigger body parts, I usually don't prefer doing a Q switch.
In fact, no, nowadays I do more of this because patients don't want that peeling and that discomfort, especially if you're doing a TCA. And a lot of them, boys, want to wear those singlets and all. So I find surprisingly once in 3 weeks, if you even just do a carbon with a Q switch, it helps a faster clearance and the compliance is better. So yeah.
So I have tried that.
Yes,
Carbon
I think
lasers,
we should try. You should not stick to the face. Whatever you're doing on the face works for everywhere because the pathology is same. Okay, last case by Dr. Rinki, and then we're going to wind up. And she has been generous. We need a masterclass with you, Dr. Rinki, soon for acne.
Yeah. So this is a case. This is typically it's predominantly unilateral. Okay. So these things also happen. Now, why this happened in this, and she's got eyelid involvement also. So that's something to note here, and that also is on the same side. Now, when we probed on the history, it was basically she always sleeps on this side. Always. I mean, when I asked her, she's a 40-year-old woman. Everything is okay. Menstrual cycle is fine. There are no topicals that she's applying. She's not doing anything. But the only history, and she's never had acne. But now when she's had a flare, it's like so bad. It's all pustular acne, scabbing and things like that. That's the only history that she gave. I really don't know whether that's the cause for the acne. But then ultimately we had to treat it. So treat it again with standard lines of management. Despite the fact that it's unilateral acne, you have to give her oral antibiotics. And then after the oral antibiotics, we did put her on oral retinoids. And that's how we are treating. She's still under treatment. So that's how we manage her. We took an off-tile reference also, just to see if there was anything inside the eye that was also there.
I think this is very typical. We also see a lot of patients one-sided unilateral. Doc, why does it only come on one side? And at times when you clear the one side, the second side comes up. So it's a very funny situation. There's no logic. But yeah, you have to counsel them, and maybe it is the travel, facing the window on that side, sleeping, use of phone, multiple reasons. So thank you so much. It has been a wonderful panel. It's important that psychological counseling, a detailed consultation, repeated inform the patients, show before, after what kind of results. Because sometimes when you treat active acne, they expect the marks also, or the scars also to go. So you have to counsel them that active acne followed by scar treatment is very important. And thank you so much for being here with us. Thank you for a wonderful panel. We enjoyed it. And thank you, Shriyal, for having us today.
I think the sound of the applause was much softer than the number of us in the hall. Thank you so much. And I would like to thank my entire panel. I know it's been a tough day being a Saturday, and not only for the panel, but for everybody here. So thank you so much for making it to this event, to supporting us, and definitely an amazing session. I think with the kind of doctors I have on my panel, and there's been continuous support from all of them, this couldn't get better. So thank you so much. I would like to thank you all with a token of gratitude. So can I have the token, please? And maybe we can keep the applause going. Thank you. We'll have a group picture with the panel now. Thank you so much. Requesting all the speakers to please meet my team member, Shenoy, outside. He would take your testimonials. Please do take your round and do visit all the exhibitors. Do continue being with us through the day. Please also take a walk to the hall too. Requesting all my attendees to continue being with us